Greetings, my name is student Dr. Jerome Trembley, and I'm going to go ahead and give a presentation on our patient Jack, who we suspect has a Zika virus infection. Jack is a 19-year-old who identifies as male who has just returned from an Eastern Caribbean cruise. He is complaining of low-grade fever of 101.3, mild annoying cough, diarrhea, and muscle aches. He also has raised red rash around the tattoos covering his left forearm. It's not clear whether it's the tattoos themselves or if it's another rash. The patient has controlled asthma managed by Flovent. Here's what we know. Jack has the symptoms that we presented on the last slide. Along with that, we know that he was traveling to celebrate his sobriety, his GED, and his sister graduating college. He was also on a cruise to the Eastern Caribbean. We also noticed that when he was in our clinic, his aches were causing Jack to move gingerly as he took his coat off. Unfortunately, there's quite a few information deficits that we have. For instance, we don't really know where Jack was. We would like to know if he stayed at a Sandals resort on his cruise and kept it nice, or if he was just exploring real third world unclean areas. We'd also like to know about the diarrhea, the timing, frequency, and onset, and if it's related to the fever. Sexual activity is particularly important for this disease, both for potential homosexuality and heterosexuality. Did he use drugs? Did he get a new tattoo? And also, did he have any bug bites of note? With the information provided by Jack, we were able to come up with 5 possible differential diagnoses. The first of which is cholera. Jack may have consumed drinking water contaminated while he was overseas. Cholera fits diarrhea and muscle aches, particularly if his diarrhea was watery stool, as well as related muscle cramps from dehydration. This is a low possibility. Although we know Jack had an addiction in the past, we don't know what that addiction involved. If the addiction involved drugs and needles, then there's a chance that an acute infection of hepatitis C may have been involved here. With hepatitis C, muscle aches are prevalent, as well as a low-grade fever. However, the lack of diarrhea, annoying cough, rash, as well as its typical presentation 2 to 12 weeks after onset, mean I'm forced to rule out acute hepatitis C. Chikungunya fever involves fever, muscle aches, and rash. It's associated with transmission by the Aedes mosquitoes that live in the Eastern Caribbean. However, diarrhea and an annoying cough are not typically present in a chikungunya presentation. As such, I was forced to rule it out. However, I do want to present a disclaimer that chikungunya fever may present simultaneously with the Zika virus via the Aedes mosquitoes. We will discuss this in more detail on later slides. We would really like to know more about this tattoo, especially if the rash is associated with the tattoo itself, or if it was just a rash in the general area. Literature supports that dirty and non-sterile conditions in tattoo parlors can produce a Pseudomonas aeruginosa infection. It is particularly prominent in hospital settings, and in the West, we associate tattoo parlors to be sterile locations. Unfortunately, in the Caribbean, that might not be the case, and that will have to depend upon where Jack went during his cruise, which we don't know. Jack may have ventured into a place that was unclean, resulting in infection. Literature also indicates that diarrhea can be prevalent based on a Pseudomonas aeruginosa infection. This covers all but the annoying cough, and was possible. The differential diagnosis that I went with for this case was a Zika virus infection. The reason I went with Zika virus is because it covers all of the symptoms, and then some, that Jack is presenting. Him coming from the Caribbean somewhere, having fever, diarrhea, muscle aches, annoying cough, and a rash all indicates that this could be possible. This table is a list of all the symptoms associated with the Zika infection. Here you can see a rash, aches, pains, fever, diarrhea, and cough. Diarrhea is not usually associated with the Zika infection. However, this data indicates that 19% of Zika-positive patients exhibit diarrhea, which is one of the major reasons I selected Zika as my diagnosis as opposed to the other choices. And here we have a picture of the Zika virus itself. The virus is an arbovirus belonging to the Flaviridae family. It has single-stranded, non-segmented, positive sense enveloped RNA, and its virus family is known to spread yellow fever, dengue fever, Japanese encephalitis, and West Nile, amongst others. It's also known for its hemorrhagic fevers. The Zika virus had its first major outbreak in the Americas just in 2014, with sporadic earlier outbreaks throughout the world. Pathologically, the Zika virus acts similar to other flaviviruses. It's typically admitted via bypassing the immunological defenses of our skin. It activates on its way in toll-like receptors 3, RIG1, and MDA5, which are pattern recognition receptors. These receptors trigger genes OAS2, IGS15, and MX1, which enhance interferon activity upon presentation of the virus. This allows our body to fight off the virus naturally. This is also another major reason why Zika virus symptoms tend to leave within a few weeks. From the CDC picture, we could tell that the Zika virus has spread throughout most of the equatorial regions on Earth. In particular, I'd like to bring your attention to the Caribbean, where we know that Jack journeyed to on his vacation when he went on his Caribbean cruise. I'd like to know specifically where he went to so I could cross-reference the cases in a particular region with Jack's symptoms. From previous slides, we know that Zika has a lot of symptoms, and we might be able to get some kind of correlation between what is presented by those cases and what Jack has today. Here we have an example of an Aedes aegypti mosquito. These mosquitoes are the primary means of transmission. The Aedes family has been known to transmit chikungunya, dengue, and the Zika virus. In particular, it could transfer all three of these diseases to the same human at the exact same time. The immunological response will produce antibodies for all three of those diseases that may affect future testing. I'll discuss that in a little bit. These mosquitoes follow the typical anthropogenic transmission style, or human to vector to human. There are other means of transmission associated with the Zika virus. We know that it can be transmitted sexually from a male to either another male or a female with the infected male semen. It also has a potential of blood-to-blood transfer through transfusions. We have been able to identify positive instances in both cases. The congenital birth defects associated with this infection have brought Zika to the limelight. Here we can see a fetus in utero with severe microencephaly and a partially collapsed skull secondary to the decreased brain tissue and subcortical calcifications. The mechanisms causing these neurological defects are as yet unknown. However, failure to develop the brain means the skull has no need to expand, and we can see that issue here with the partially collapsed skull. Additionally, an infant may present with scarring to the back of the eye, limb contractures, and defects such as clubfoot and systemic hypertonia restricting body movement. As previously mentioned, congenital Zika syndrome will present limb abnormalities such as clubfoot and microencephalopathy. We can see two examples for both on the left and the right of microencephalopathy, and the left has an extreme example of those limb developmental abnormalities that I mentioned. We do need to keep the patient in mind, and since the patient is in fact a male, he will not have these issues. In his regard, we can tell him that symptoms should alleviate within 5 to 7 days. I do want to make sure that this patient knows that there's a correlation between Zika and the Guillain-Barré syndrome. The mechanism for this is not understood. We do believe that there is a strong correlation between Guillain-Barré and Zika, but not all patients with Zika will contract Guillain-Barré. We need to begin testing immediately. It's important to know that Zika, dengue, and chikungunya all circulate using the same mosquito. Therefore, it's possible to have all three diseases at the same time. This means that the primary means of testing, which is a Zika MAC ELISA test, which checks for the antibodies associated with the Zika virus, may also show cross-reactivity with other flaviviruses involving dengue and chikungunya. So if we have a positive, we need to use the gold standard, which is RNA nucleic acid testing for Zika specifically. We should also test for the other two. Plaque reduction neutralization testing is offered by the CDC as well for Zika. There is no cure or vaccine for Zika. The first thing is testing. As previously mentioned, we will perform the test in accordance with CDC guidance. As Jack is a male, we will forward his information for plaque reduction neutralization testing to identify exactly what virus is causing his issues. However, we have to treat his symptoms with supportive care only. Rest and acetaminophen for fever are appropriate, and because he has a fever and diarrhea, we need to make sure he's getting plenty of fluids. We will not be giving any sort of NSAID to Jack. This is because NSAIDs may cause hemorrhages with dengue fever. It's a contraindication for that disease, and since we can't rule it out yet, we'll hold off. Zika has its share of ethical concerns that we need to address with Jack. First, any Zika positive result needs to be reported to the CDC. This may violate Jack's perception about his own patient autonomy, as well as his concerns for HIPAA. We can alleviate some of these fears by explaining that we are only giving this information to the CDC for tracking purposes and not his own personal information. Another major issue with Zika is that it is a sexually transmitted disease. And because he has the symptoms, if he is Zika positive, he may inadvertently transfer that disease to a pregnant woman. Any pregnant woman with this disease may face severe complications of the pregnancy. This means I need to educate Jack and make sure that he's using a barrier means of contraception. He may take offense to this because, again, we're insulting his autonomy and privacy, but it is important that he understands the risks involved. Of particular note, there is a high load of virus still present in semen up to 62 days after the onset. So even if he feels better, he may still have the infection. Lastly, we may insult his personal autonomy by asking him to wear mosquito repellent during mosquito season. As mosquitoes are the primary means of transmission, avoiding getting bit would be a good idea. Thank you for listening to my presentation on Zika. This concludes my presentation. Here are the associated references for your review. Special thanks to Dr. Gomez for assisting with Zika research, Dr. Farrell for assisting with clinical application of this disease, and Dr. Town for the immunity discussion regarding the Zika virus.